Hi, welcome to episode 69 of Yoga Research and Beyond. I'm Ariana I'm the founder of Yoga Research and Beyond and this podcast, also strength trainer yoga teacher in New York City and co-founder of New York Stretch.
Hi, I'm Jules Mitchell, and I've recently partnered with Ariana on the newer version of this podcast, and I'm so excited to be here. I live in Las Vegas, and I teach yoga teachers. I teach yoga to yoga teachers, mostly in biomechanics, anatomy, and research literacy. So I found this study just in my I'm always reading research, so I came across this study, and it really caught my attention because it's about synchronized breathing, and we tend to do that in yoga. So I shared it with Ariana, and here we are today. I'll let her introduce you to the study.
Awesome. I'm really happy that Julia brought this to our attention. As I read it, there were just more and more layers of things that I appreciated about it. The title of it is Identical Movement Control Exercises with and Without Synchronized Breathing for Chronic Nonspecific Low Back Pain. And it's a randomized pilot trial. It was done in 2024. It's from the Journal of Back and Musculoskeletal Rehabilitation. It was done in Finland. I'll give you some basics about it here. You have some idea of what they were doing. They had two groups. They had a control and what they called an experimental group. And in the experimental group, they added the breathing. But otherwise, both groups did the same exercise program. And the exercises that they chose, I wanted to dive more into it, but I didn't have a chance to really look deeply into it. I will later. They were a set of exercises, from what I understood, put together a researcher at this program. They had 4 clinic visits throughout the 2-month intervention, and the clinic visits were done by the same practitioner, same clinician, whether it was the experimental group or the control group. And then they were asked to do the exercises on their own at home. So both groups had to do the exercises on their own at home, and they had to keep a journal of everything with very specific questions about it. 30 people ended up participating in the program. It wasn't exactly split evenly, which they talk about as one of the minor issues with it. There were 16 people in one group, 14 in another. The adherence, the people that stayed throughout the study, was pretty high. There were more people that dropped out of the experimental group, but it wasn't because it was difficult for them to do. It was because they had COVID and other health restrictions or health issues that came up. And I'll go over a couple terms with you here. One is PROMS, which is one of the acronyms in the paper. It's the patient reported outcome measurements. So that just means that's their journal entry, and that's what they entered as part of the outcomes in the study. And the next thing is the acronym CNLSBP, which is just the chronic nonspecific low back pain, which I remember when I started looking at research about this is used constantly, this acronym, throughout studies like this. And it just means that it's not an acute injury. It's not a diagnosed injury that needs surgery or serious care. It's an ongoing pain, generalized pain for like 3 or more months, typically, sometimes 6 months. Anyone who tried to be in this study who had a specific diagnosed injury was excluded from the study. So it had to be this like general, non-defined achiness to be in the study. You want to jump in?
Okay, so I did have a chance to dig a little bit into the exercises that they did. They were just like things they weren't yoga poses, but they were things that show up in yoga, like lunges and cat-cows and like kneeling, pushing back toward child's pose, coming back to kneeling, things like that. The exercise program was published in actually another paper because you're right, one of the authors has developed it and worked on it apparently in other studies. So you had to kind of go dig for that paper to find it. But the exercises, from my understanding, were not exactly the same. They were individualized because you had talked about how they went to visit a a physio or whatever every other week for the 8 weeks. And then they'd do it at home practice. And I believe the way it sounded in the paper was that it was modifiable. They were choosing from the same exercises, but it was modifiable for the person, which, to be honest, really tracks with the entire nature of this paper. I felt like this paper was extremely modern. It had very current awareness of pain science. And I think that the ability to individualize at-home practice is a reflection of just the overall body of literature that is really trying to promote self-efficacy for subjects or patients in pain and giving them the opportunity to do home practices. So this isn't the first time we're seeing something like that. And so I thought it was just really sensitive to our current understanding of pain science, which is actually one of the reasons why I liked this paper so much. Even within how you mentioned the patient reported outcome measures, there was the diary, and they had very specific entries that they needed to put into the diary, like if they were doing any other pain treatment, if they took any meds, of course, what they were doing for the intervention. But they also had a series of questionnaires, which is very common in patient reported outcome studies, right? They had a series of questionnaires that they had to fill out. And even those questionnaires were very modern. Like we have kind of the visual analog scale, pain 1 to 10, or 0 to 10. Everybody knows about that. But there were some in here that were just had a really deep understanding of what we're studying today in the world of pain science. They had a pain catastrophizing scale, which I thought was wonderful. They had a pain self-efficacy questionnaire. They had one about sleep. They had one on general anxiety. They had the sensory sensitization inventory. So it just felt like it was just aware of where the research is going. And I'm saying that because we're known for reviewing bad quality papers that really sometimes you're reading them and the ideas feel outdated. The assumptions about exercises feel outdated. And this one just felt like really self-aware, which I thought was really cool. Do you want to add to that before I go on to my next list?
That was one of the things that I got really excited about was looking at the questionnaires. And I love that these are official questionnaires.
Mm-hmm.
So, and also the TSK, the Tampa scale of kinesiophobia.
Mm-hmm.
Like, I just love that it's a scale and it goes from I think it was 17 to 68 points. That's the range. I wanted to know what these ranges were that they chose. I'm curious how they put them together. The PCS, which is the pain catastrophizing scale, goes from 0 to 52, and a change of 8 points was a meaningful change when they were doing this. And then the pain self-efficacy questionnaire was 0 to 6. So I really appreciated those questionnaires as well, because I haven't seen those in this kind of study. So that was really cool.
Yeah, you don't. I mean, I'm hoping we see them a lot more now. But yes, traditionally, historically, these are not questionnaires that were produced in the 50s. So they're new. And I'm sure that there are plenty of validity studies on some of these questionnaires and reliability studies on some of these questionnaires out there, which maybe we can review one if that interests you, because you can't just pick a study or pick a questionnaire and then validate it without doing a validation study. So I'm sure they're out there, but it is really cool to really be on board with the position of the researchers. I think a lot of times stuff just feels dusty and cobwebby, and this was not that.
Yeah.
Okay. So do you want to add to that before I go on?
A little bit. I mentioned that it's a pilot study. So that means that it's a beginning study and they want to see if it's worth investigating more. It's done on pilot studies, usually done on a smaller scale. So that's all.
Yep. Okay, great. Perfect. So that's exactly where I was going to pick up. So thanks for the intro to that. So they had two main aims, and one was for feasibility. So we've talked about feasibility studies before on this podcast. Can this study be reproduced and can we use the measurements and can we use the study protocol? So that was the first part. And they actually measured feasibility by two main things, which was, could they get enough enrollment? Right. And in the time frame, not just overall, but in the time frame that they had, because, when you get funding for a study, there's a beginning and end, and people get paid and then they don't. And so you only have so much time to recruit. So that was the first question. And the other one was adherence. with the people that they were able to recruit, were they all able to adhere to the protocol? And both of those were effective, so that they were able to do that. They got 30 out of 121 that were eligible, and then they were able to adhere. It's funny when you were talking about dropouts, that because the numbers were low, the percentage was actually high, but it was only a couple people. So it's, when you're doing pilot and feasibility studies, that's okay when these percentages are high, because again, it's because the power of the study is very, very small. And we're not taking the information and the results from this study and making real world conclusions. We're making sure that the study can be produced on a larger scale. So it was low dropout rate, even though the percentages looked high, I guess. And then the other aim of the study was to measure preliminary efficacy. And I'm going to say that word again. And I know we've talked about it on the podcast before, but efficacy is about the internal validity of the study versus the external validity of the study. That would be effectiveness. So efficacy with an I, internal validity, effectiveness with an E, external validity. So what it's going to try to show, or what the point of the paper is based on the study design, do the outcomes, these PROMs, does it work? Is there an improvement? What we can't do is extrapolate the results to real world results. So it's just to see if within the containment of the container of the study, with a very controlled environment, are we able to get outcome measures that are favorable? And if that's the case, then it would be reason to do another large study and then another large study so that we can eventually extrapolate these results to the real world. And why that is so important to understand is because somebody who doesn't know that will look at this paper, read the abstract, and say, oh, look, adding synchronized breathing to exercises reduces back pain. And then make that conclusion that it exists out in the real world, but that is actually not what they set out to measure or conclude. It's good to understand the difference. Anything you want to add to that? I have some other things I want to talk about.
No,
okay. They did a really good job in the results section near the end in their discussion, saying that the study was not powered to test for differences between groups. So they didn't even really analyze that. I mean, they did report data, but they didn't analyze it because there weren't enough people. It wasn't powered in order, large enough to be able to see what the significance was between the group or what the effect size was. And they were honest about that. Again, if somebody's not reading the paper and just looking at the abstract, they might not understand that. And then what they really were trying to look at when they were doing the feasibility part is, does adding synchronized breathing, does it add, I think the words they used was a significant burden to the experimental group? Because that's one of the big issues when you're adding something to a protocol. I remember even just looking at years ago when I was writing my book, it was adding yoga to an athletic team, to their training protocol. And that was one of the questions is they're already training so much. It was an Olympic speed skating team. They're already training and practicing and nutrition and sleep and coaching and all the things. And then now we're adding 2 hours of yoga a week. Is that a significant burden? Or is that something that we can do? Will it create injury or whatever? And so that was the kind of the question here is they're doing these exercises that have been shown to be valid and reliable in other studies. And if we add the breathing component, does it make it where the dropout rate is higher, or where suddenly they can't follow along and they can't keep up with the intention of the study or anything like that? And they found it didn't. So this is a really good foundation for a larger scale study.
Yeah, and along those lines of adding a burden, it wasn't only for the people involved in the subjects of the study. It was for the clinicians, for the people teaching it. Yep. So they learned that doesn't take a lot of time to teach this for people to then, to understand what this is and then share it with their subject. So it's all in all, not burdensome for the people giving the intervention and then the people participating in it too. Which I thought
that's a win.
Cool.
And then real quick, before I get into the last little part I want to talk about, which is about trial registry, but I do just want to say it because I did look into the exercises that they did. I'll just give you a simple example of what the synchronized breathing looked like, just so that everyone has an understanding. Like imagine you're standing and you step forward into a lunge, like a high lunge, and you step back. It was like inhale, step forward, exhale, step back. It was like simple like that. They had another one that was like being in quadruped and like kind of hinging forward and hinging back, like not all the way to a child's pose, but almost to a child's pose, forward and back. And it was like inhale, come forward, and exhale, come back. And there were like three main things. It was breathing in and out through the nose. It was focusing on like belly breath. That was a little vague, but just kind of, think of expansion. And then the inhale and the exhale. And that was pretty much it. So it wasn't like some complicated, like when complicated yoga vinyasa sequence where you have to remember what the breath is, it was just like back and forth. The same exercise had like two components, in, out. So it was simple. And they had other positions like cat, cow, dead bug, bridge. Stuff that shows up in yoga. And they did acknowledge that yoga, that like the synchronized breathing is a feature in yoga and Pilates, and that a lot of these practices are used in chronic low back pain research, nonspecific chronic low back pain research. But what I really liked was they didn't really like touch on the mechanism. They were just looking to see if it was feasible. Like, is it because of, pressure changes, or is it because of mindfulness? Like what, they didn't really go into that. And I think that would be a fun conversation for us to have.
Of course, I went there too. I was like,
what are your thoughts?
Okay. It's multi-layered because when I first started teaching yoga, it was really important with where you were doing the inhale and where you were doing the exhale, like always with extension, inhale, always with flexion, exhale. And now it doesn't matter. Both are good to me. And so I could see old yoga teacher me getting caught up in the, when were they doing the inhale? When were they doing the exhale? And now I think it's more just like, it's just focusing on the breath. That's all it is. And maybe it's vagus nerve stuff, stimulating that, the mindfulness. But I think it's just that simple parasympathetic, not so simple active.
If you wanted to measure if it was more of a mechanism of pressure or posture position, you would have to compare them, inhale here, exhale, you'd have to, it'd be a whole different study. It'd be a whole different study. So I think it was just kind of relying on the focused attention. Again, maybe self-efficacy is a part of it, just something rhythmic, being more in like a flow state. Who knows?
Or maybe the one-on-one attention with the clinician.
Yeah.
Sometimes that does it. Or the self-reflection in the diary.
It'd be also interesting to see if, like, in a study where there's a third arm where they don't do the exercises and they just do breathing, like almost like a visualization of the exercises, but breathing in and out. That would be really cool to compare, exercise versus exercise with breathing versus breathing with visualization. Anyway,
I wanted to talk about the efficacy versus effectiveness, and the results were so good from this study. That 9 out of the 11 outcome measurements that they took saw improvement with the breathing group. So even though, we can't extrapolate to, I guess, a regular practice based on that, but that's a really good outcome to have from this kind of study, which also, it's not just that it was a good study and the adherence and all of that. Those measurements, those outcomes are also incentive to do another study and make it, a larger study. So I thought that was cool.
Yeah. Again, in these controlled conditions, it is an efficacious. The results are efficacious, right? That is good. Yes, 100%. And also, I think some of the control group had improvements as well. It wasn't like the control group didn't improve. They all did well, but the breathing was great as well. So
but it was more significant with the breathing.
Yeah, very cool. Okay, the last thing I want to mention, because we're getting close to our self-imposed time limit, and that is that this study pre-registered their clinical trial, and that was at the very end of the methods section. They actually have a link to where they registered the trial, and because there's different databases where you can do that. And also like the number, you get a number. But what is so special about that, and you don't see as often as you should, is really promotes transparency in research studies. Research is a business, and publications in a journal are profitable. And so here we are in capitalism. And so what ends up happening is researchers design their study, get approval from the ethics committee, from the IRB, they do their study, and they find that the results aren't what they want. So they end up doing something we call data mining, where they look at the data and they manipulate it in different ways until they see a pattern. And then when they have a pattern, then they change their hypothesis, or they change their, and now they have positive results and they're more likely to get published. I know this is a cynical way of looking at research, but it happens. And so one of the things that has happened since the internet, because now we can publish all this on paper, you can upload it to the internet, you can pre-register your trial. So you basically give an outline of everything you're going to do, and you disclose your hypothesis, you disclose your methods, everything. And then when you publish your study, people like us can go and make sure that what they did in the study matches what they said they were going to do. And what's also really nice is within that, you can also publish your data sets so that other researchers can look at your data and run the statistics to verify that they were done properly and that they are accurate, because mistakes happen. So anyway, I thought that was very cool. I know that these different registries exist. There's, a handful of them. You can just Google, clinical trial registry or research registry. There's many out there, but I just don't see it very often. Like we talk about it in the research world, but this was right there, right at the end of the methods section, complete transparency, check out our work. And that I thought was pretty cool.
Yeah, thanks for explaining that. I was wondering what the significance of that was.
Mm-hmm.
I don't think I've ever seen that in the studies that I've looked at. And I was also going to ask you about when I read that it wasn't powered to test for differences.
Mm-hmm.
So thank you for going over that too. Yeah.
There's a calculation that you can do that I don't know off the top of my head, but there's a calculation that you can do based on the types of statistics that you're going to run and the data analysis you're going to do, where you kind of like calculate backwards to see how many people you need in your study for it to be powered appropriately to measure effect sizes and things like that. Any mathematicians out there listening will know exactly what I'm talking about. So it's kind of like you say, this is what I want to do, and then you work backwards. This is how many people we need. But
cool. Yeah. Cool. Yeah. This was a really great study.
It was a great paper.
How we put together the self-reflectiveness of it so that it could be, repeated, and just so
all the transparency. The writing was good, and just to like, we read a lot of research in my mentoring program. And like just this last week, we had a group call on it. One of the questions of the paper we were reading is like, are there any statements in the paper that are like, assumptions that the author has made that you don't necessarily agree with, like those are common things that I'm looking at in research. And that didn't exist in this one. It was really like an honest, truthful paper.
There was one tiny thing where I was like,
what? Where'd you see? Never mind. It's not perfect.
It's so little. It's in the introduction. It's a second paragraph. Exercise interventions incorporating specific breathing techniques like yoga and Pilates are among the most effective exercises. I've never seen yoga and Pilates being more effective than others. So it was just that they singled out yoga and Pilates as opposed to just exercise in general. But it's so minor. It's not really.
And there are studies out there that show that it is more, but that again is just a couple studies. But so it's not a full on conclusion that we can all make, but you can cite that after a few papers. You can't.
Yeah. But yeah.
Cool.
Awesome.
This was fun.
Yeah. Good one. All right. Thanks, everybody.
Cool. We'll see you on the next episode.